Most of you know me. I'm Dr. Alan Winter. I practiced family medicine for 30, 38 years and have worked a lot in computers and healthcare. Today, we're going to talk about with my good friend Chuck Zelnick, and he'll introduce himself in just a second after I describe. But we're going to talk about trust in healthcare and how AI is going to impact how healthcare is delivered over the next session or two. So, Chuck, take it away.
Hi, my name's Charles Zelnick. I'm a family doctor since 1982, and I've been mostly a rural doctor most of my career in a little town out west and in an island off the coast of Maine. And in the middle of that, did some teaching at the Standard Practice Residency in Iowa, where I got interested in computers mainly for figuring out how to use them for patient education, how to help patients do what needs to be done. And from that, my interest in using electronic medical record systems and now into AI has been evolving. It's very interesting over my career to see how it's changed.
Has anyone ever considered that maybe their next doctor might be a robot? Because it seems like you really can't get a doctor these days, and the opportunity to have a family doctor is really declining because of a lack of um of physicians. So we don't know what the future is going to be, and we're going to talk about that a little bit. Um, what do you think,
Yeah, I
Chuck?
just read the other day that the United States is already short 68,000 doctors. This was an article about the H-1B visas and the international medical graduates. So we're already behind the eight ball as far as the number of physicians we need for the population. And as our generation, the baby boomers and the generation after us, all are aging out into their 60s, 70s, and 80s. The geriatric population, which is the one that uses medical services the most, is just ballooning. So there's going to be a great pressure. There's already a lot of pressure on the medical system or non-system in this country for access. And I see that AI is going to be looked at as, is this a tool that can somehow impact what's happening?
It is, and I think that's what we'd like to address. But before we do that, we got to think about trust and trustworthiness. There's a book that just came out that really summarizes it about as well as we can. Healthcare AI is really about trust and trustworthiness, and that's what our topic is. Where do you think that comes from, Chuck?
Well, I think there's a long history of concerns about computers making mistakes or the wrong information being in the computer, or certainly as we've seen the EHR, the electronic health record, evolve over the last 25 years or so since the turn of the century. Accuracy of the data has already been a big issue, even before you add generative artificial intelligence into the mix. So I just would put a plug in for Dr. Wagner's book. I think Alan and I both read it, and it's a really up-to-date sort of deep look at healthcare. And I think one of the things he points out is that using systems in a way that is ethical and trustworthy is the big challenge. It's not so much whether the systems are accurate, but can we use them in a way that is safe and that we can all trust and feel like it's being used for the benefit of patients and not for the benefit of people who aren't patients or who have other interests such as financial interests or interest in accessing your data.
And certainly trust in everything health is really declining. And I think a lot of that is because we've seen over the last 20 years basically that medicine's really become a business, and physicians have lost their independence to become employed by uh, large health systems, and the systems are run by administrators, and they have MBAs, and their major goal is to make money. So it becomes a quandary to the patient. Is the doctor ordering this test because he has to in order to stay to keep his job, or is he ordering it because I'm supposed to get it? And I think that's a hard that's a hard question, isn't it?
Yeah. When I first went into practice, I was in my own private practice with a couple other guys, and it was a business, but we really controlled how often we wanted to be in the office, how many office hours we had when we came in, when we left. We had hands-on control of, did we want to spend money for a new blood counter machine, or did we want to hire a new nurse to help out in the back? What kind of computer system did we want to put in to do billing at that point? So we really were, it was a lot of work, but it was hands-on and we had a lot of control. We've seen that control go away as physicians in general have become employees of bigger healthcare systems. And when patients would ask me these questions that I have on the slide here are generally questions that have come from my own patients who said, who've kind of pushed back against advice that I've been giving them. And I think it was easier to answer some of these questions when I was in my own little practice and had control over everything than when you're sort of a cog in a bigger machine. On the other hand, I have to say there are some advantages to being in the bigger system, and that it's a little more seamless to get your consultations ordered and get the information back. But it does all come back to trust, and the patients are saying, how much money are you making off of these tests? And the administrators are saying you need to see one or two more patients every day so that your clinic stays in the black. And then we have all the sort of public health things going on that I've listed on the slide. The opioid epidemic, where doctors were actually part of the problem, the vaccine hesitancy that started with COVID, and now we have, with the internet, patients doing their own research and getting information from all sorts of places. I found it interesting. I found a recent study done in March of this year by Kaiser Institute, which looked at AI medical use. And only about 1/4 of adults in America have used AI to get medical information. But of those, 31% didn't trust the answers that they got. And then if you ask people who don't use AI, would they trust the answers? 82% said they wouldn't trust the answers. So I think we don't have to worry about the country trusting the artificial intelligence, especially the large language models, more than doctors right away. But certainly we're seeing that people are using it for, as you said, a second opinion. And I think, if we walk through this from the patient's point of view, I think it will highlight how artificial intelligence and decision support tools for medical practices are not going to solve the problems with our medical system by themselves. It's going to have to be an integrated approach. So as we talked a little earlier, I thought we might walk through as what this looks like for patients. What do patients want, and how do they look towards artificial intelligence and generative AI? What concerns do they have? And we've done a little background work on this. So, and the background work I did was I talked to the smartest woman I know, who's my wife. And but some of this discussion came up because we moved to a new town, and in November she called one of the local doctor's offices, and she wanted to see a woman physician. And she called up and said, "Could I get an appointment? Could I transfer my care?" And they said, "Yes, we'd be happy to see you in January." They said January of 2027. So for access, she's unable to access a new doctor for over 14 months. And this brings up the whole question of access in the system, which so access is a huge issue. And she said, as far as access, she wants to be able to see the doctor when she needs to see the doctor, and not have to wait 14 months. And particularly, she's concerned she doesn't want to see the AI first.
Certainly. I think all patients feel that way. And yet so many are looking at the internet when they have a symptom. And without a doubt, the issue of 14 months is ridiculous. And even my wife has trouble, and she has a regular. We have regular physicians, and and we can't get an appointment to see our doctor in less than several weeks. I mean, it'll probably be a month if I called up right now to try to get an appointment with my doctor. So if you're really sick, what are you going to do? I mean, certainly they have nurse practitioners, but um, that sometimes that leads to more problems than cure, depending on the quality of the person's knowledge of your case. And also they have telemedicine, but that's outsourced to another organization. So that doctor doesn't know anything about your care. And you can do e-visits, but they're limited to, I think, 12 things. So unless you can bend your complaint into a symptom that meets that criteria, you're really left with a disjoint sort of system of being unaccessible as far as I can see. And I think the experience that you've had is pretty normal. You can't find a doctor these days, which I
Right.
guess is what has led to the advent of concierge medicine and direct primary care.
And it is not only just access. I mean, you can always go to a walk-in clinic or something like that, but it's access to continuity of care, which we really, really, I think that's what everybody wants to. You want your own doctor, somebody who can get to know you, so that you don't have to reinvent the wheel and re-educate your provider that's caring for you right from the get-go. Every time you see somebody, nobody wants to see somebody new every time. And I can attest to this. I've had 5 new doctors myself in the last 10 years. So I just get one guy trained and he move away. And living in rural Maine, this has been quite a difficulty. I do want to say one that this speaks to the importance of having systems that try to build access and promote access, not just by adding more providers or adding more appointment slots, but by being smart. And the story I have about this is that when I was teaching in the residency, we had a real problem was, we ran an obstetric service, and it was obstetric service mainly for underserved people or people who didn't have insurance, would be seen by the residency. So we wanted to get them in, and patients were calling up and being told, just like my wife was told, well, yeah, you're pregnant, but we're going to see you in 2 months or 3 months. Well, if you're 6 months along, that's not prenatal care. If you're going to be seen in 3 months, you're going to be delivered before then. So we looked at this problem and we said, what's the problem getting them in? The problem was we didn't have enough long slots for that very first visit to get them in and get them started on prenatal care. So what we did was we got a computerized program that would take all the questions that we wanted to know about that patient, and we would bring the patient in and have them sit down and go through that question list, and then have the nurse triage them. She would get their blood work done, the standard blood work that you do at the first visit. She would get them in an ultrasound if they were due to that or needed that. She would get them started on the prenatal vitamins, which is something you really want to do right away. And she would take the question answers, the history, and run it by the physician and say, is there anything here that's going to be a problem that they can't wait for another month to come in and see you? So actually, they had a first visit done by the nurse that was doing all of the sort of routine things. And by the time the patient came back to see the resident, and these are resident doctors who are slow in the first place because they're still learning, we give them extra time. Instead of taking over an hour for that first visit, we got it down to 40 minutes. And so we were able to put more slots in and get the patients in, and all of the quality measures of the visit went up just by re-engineering how we did the access and using a computer to ask them questions. And we did this in 2 clinics. We were able to replicate it. So thinking outside, and saying, well, we're just going to have the doctor, we're going to have the AI see you first is not the answer, but having your staff look at how the patient flows through the clinic and re-engineering that made a huge difference, and we were really pleased to be able to do that and improve the access to our patients, and not have them come in for their first prenatal visit the week before they delivered.
I did have a role in designing that system that he just described, and that's originally how we met. But the point to it is that really patients improve access, they can really help. And using a tool like the expert system that this is to screen the patients actually augments the nurse, and it's really an assistant just to ask questions, and that's really a low level of fixed AI, if you will, and it's been useful for practices for 30 years now. So
Yeah.
that
And
that's
our
an
no-show rate,
example.
yeah, by doing this, our no-show rate went down too, because once the patients had seen the nurse and answered all those questions, and there were 5 pages of questions, they wanted to see what it meant. So they'd come back to see the doctor, and they were already established. They knew where the patient was. They knew where the office was. They knew where to park. So we didn't have people not showing up for that 1 hour visit.
Exactly, and that no-show rate is a really big problem, especially in underserved areas where they have long distances to travel, or they may have transportation issues of paying for the travel, gas prices, and so forth. So the advent of these types of technologies evolving into telemedicine, which I've also had a great deal of experience in in terms of bringing it online is where we need to be. I mean, we've got to use these technologies to improve access, and I think we can if we can define what we need and make sure they're trustworthy, and the the information is accurate. And I think that's been established in some of these types of systems that we've just discussed.
Having the human plus the computer system really is a good combination, because you get that warm intake, even if the nurse is doing it. Patients will call up and say, "I'm pregnant. I need to be seen." They'd say, "Fine, come in this week.
Right.
Come in
And
tomorrow."
you couldn't do that any other way
Right.
except with a computer that would augment the nurse's work because they're busy as well. So if we think about how the system might work, it's really an assistant. And I think that's the best way to consider AI, is maybe it's a co-intelligence, and that's exactly what we're describing. And I think we can use AI to improve access, and I think that there's many opportunities for that.
So the second thing that my wife said she wanted to have was caring, and she defines that as having more than 3 minutes of the doctor's time and not feeling like she was on an assembly line. So again, that comes back to scheduling, and the concern here is that will the AI push out the ability of the patient, of my wife, when she's seeing her doctor, to actually feel like the doctor's hearing her story and thinking about it with enough time to make a decent decision. I got to say, my story about this has been one that just in the last few months I've been working at the free clinic and doing some fill-in work at my old office, and we now have a, a through computerized scribes, artificial intelligence scribes, such as you can get them through Open Evidence and through Doximity. There are a bunch of private companies, and our EMR, which is a Cerner Oracle EMR, has a built-in clinical agent. And
As
what you do
does
is, Epic
Epic. So
does too. Yeah, and you put your phone down and turn on the recorder with the patient's permission. And the thing that I like about it is that I can just sit there and talk to my patient, make eye contact. I put the computer aside, and we're just talking and doing examination. And it really frees me to have a much better contact, where I felt like for the last 25 years the computer kept getting into the way. Uh, in order for me to be able to see the patient, I had to have information that, or be putting in information while I was seeing the patient. And there's that. I
absolutely.
think you had that, you referenced that picture that was on the cover of the medical journal with the doctor and the
Oh,
little
that was
girl.
written, yeah, right. There was a drawing that was on the front page of the Journal of American Medical Association that like an 8-year-old did, of a doctor looking at the computer and had his back to the patients. And that's exactly what has happened with the advent of the electronic health record. Is you took the it takes probably 3 to 5 minutes, half the time, for the doctor to put the data into into electronic health records. So when those came about 20 years ago now, they really turned doctors into data entry clerks, and that's really inappropriate, and it took half the time. So that's why your wife is complaining about the 3 minutes. I mean, it's real. Doctors don't have enough time, and that certainly the process that you just described will help make that time go better. Also, pre-screening with the um, uh, expert system of interviewing the patient can get all the negative questions out of the way. Like if you come in for abdominal pain, you need to ask the patient if they've ever had abdominal surgery. And if they've had no, you don't have to ask them about that. And that way, you don't have to spend time with things that are not wrong with the patient. You can concentrate on things that are wrong with the patient, and that increases the amount of time that you can spend face to face with the patient without worrying about the computer.
Right. And the additional way that we would hope the artificial intelligence in medicine would assist with that is to get rid of a lot of the administrative trivia that doctors spend between patients or after or before the day begins, which just eats up so much time that you could have been spending with a patient in the exam room. But you're spending it on the phone talking to insurers to get prior authorization or writing letters or looking up, you know, um, answering emails or electronic messages that are,
And AI has
yeah,
definitely stepped in to do a lot of that. I wrote an article recently on how to object to a denial in one of my essays, and that's AI can do it, and it's very effective.
yeah. My fear of that is that we're going to um, the the answer to the prior authorization problem will be, oh, just give the providers, the physicians, give them AI to do the letters instead of let's just get rid of the letters in the first place, the need for them, and have a better medical system. So we don't want to let artificial intelligence become a band-aid for a broken leg.
Good point.
Yeah. So this is the one that most people think about when they think about generative artificial intelligence, and that's case information. So my wife, when she sees the doctor, she wants the doctor to be knowledgeable and be able to find all of her case information without fumbling around looking for it. And she wonders how AI tools will interact with the electronic medical record. And we already said at the beginning, an electronic medical record is not always accurate or complete, or maybe not doesn't even have half the story if the patient's been in two different health systems. And then she worries about who gets to use her data. Um, so I don't know. You want to comment on this, Alan, and then I'll jump in.
Yeah, it's clear that the EHR the health record has certainly helped doctors. We don't lose information like we used to, but how's the AI going to help us? It can bring the information together and certainly summarize it, but if the information in the electronic record is wrong, then it'll give us the wrong information. So we have to be careful if we take data and then have it interpreted by the artificial intelligence in such a way that we may get misled. And I think that's a real concern um, in terms of using generative AI inside the health record. And we're going to address a bit of that later when we really get into how AI works.
Yeah. The story I think about this though is that this has been a problem with the human brain, and the case I think that's most illustrative was a doctor saw a patient who had a history of PE or pulmonary embolism, and the patient said, "Well, I don't think I ever had a blood clot in my lung." And when the doctor went back and looked through their medical records, you had to go back years and years to finally find that somebody had used the abbreviation PE for a physical exam, and a previous physician had mistaken that for pulmonary embolus and put that into the past medical history. So, and then this was carried forward for years as in the past medical history as the patient had a PE or a pulmonary embolus. So if humans can do that, we know that the AI will be able to do it even more efficiently. So I think the patient is always the ground zero when it comes to is this information correct? And I had a lot of concerns about putting the patient information on the portal for the patient to be able to read all of their notes and their discharge summaries and everything. But as once my health system did that, I became much more comfortable with it. And unfortunately, I don't think patients probably look at that data enough to find the errors that we have made. Because when you're writing down 1,000 things a day, you're not going to get 1,000 of them absolutely correct. And I think that we have to encourage our patients to be engaged with their healthcare and make sure that the things that are in the record are actually true. That they didn't have a PE, they just had a physical exam at some point.
Yes, the case information is so important.
Yep. Yep. So the corollary to that, my wife wants to know that the doctor knows her past history. She also wants the doctor to look things up because she's married to a doctor and she knows that the doctors don't know everything because of that. So um, uh, she knows the doctor doesn't know a lot of things, and she doesn't want the doctor to guess or blame her problems on hormones or nerves or something that is not germane to her case the way she sees it. And she worries that artificial intelligence will just tell her what she wants to hear. And we certainly know that this has been a big problem with generative AI, that people have actually fallen in love with their chatbots because they're so nice to them and they're nicer than any boyfriend or girlfriend could ever be, and so sycophantic. Um, so, but we also know that this could be a great tool. Um,
As
one of my
an
favorite
assistant, as an assistant,
as an assistant, yeah.
like a
One of my fa-
librarian or a research assistant.
Yeah, one of my favorite studies was one that one of my colleagues did at the University of Iowa, where he had medical students or research assistants follow the doctor around all day long, and after each case, they would ask him, "How many questions did you have?" They would ask him or her, "How many questions did you have about that case you just saw?" And it turns out consistently, not only in Iowa but across the world, doctors have one important clinical question for every two patients they see that goes unanswered because they don't have time to look it up. So one of the great things I've seen in medicine since I was a country doctor in Washington State, 40 years ago, back then I'd have to either go find a textbook or I'd call somebody up at the university to get an answer to a question. It was just not easy to do. Now we have UpToDate and we have Dynamed and we have reference case materials that are like textbooks online that you can search and find an answer really easily. Um, the AI systems are coming along to work similar to that, and I've been using Open Evidence lately and some Docs GPT to get answers. So I recently saw a patient who had stopped, who had latent TB and is from Africa, had stopped his TB medicine after 1 month because he couldn't afford or somehow couldn't get the refill. And so the question in my mind was, gosh, do I have to restart the whole 3 months of treatment for latent TB, or can I just do 2 more months? And it was very quick to look at Open Evidence. I put the question in and got the answer right back, and said, no, we have to restart. You have to do the whole 3 months. So that's the kind of thing that I
That's
maybe
perfect.
would have had a really hard time finding the answer to when I was a doctor in
You
Quincy.
basically would have needed to call an infectious disease consultant.
Right, right. And being able to get that right at the point of care is a wonderful thing. And
Certainly. I guess for our last topic, we'll just kind of summarize with the partnership of doctors and patients.
yeah, this is where we need to talk about um, trustworthiness and locus of control the next time. My wife says when the doctor's making decisions about her healthcare, she wants to be involved in those decisions, and she doesn't want to have the computer telling her what to do. She wants to see a highly trained human being she can trust, and somebody who's also applying their own judgment. And I think this is going to be a real challenge for doctors and providers going forward, is that it becomes so easy to look something up in Open Evidence or to put a whole case in, like a hospital discharge, dump that into the generative AI and say, what should I do about this patient? That then you abrogate your responsibility to actually do the thinking yourself. And there is some data that when you have to write up your own notes, when you have to think about things, um, you're going to do a better job for your patient. And I think we don't want to see the loss of that intuition. I can remember specifically really uh, some really important cases where I remember one back when I was first in practice in Washington State. I woke up in the middle of the night and said, "Oh my goodness, this guy that's been coming in with edema that doesn't get better with Lasix, I haven't checked his thyroid."
Exactly.
And I called him the next morning and said, "Come in and get your thyroid," and his TSH was off the scale. And it's that kind of thinking that, going on to even an intuition that wakes you up in the middle of the night and says, "Wait a second, I've been thinking about this guy. Something's just not right here." Um, the flip side of that is that
We have all had that experience, and certainly until the AI is much better than it is now, we're still going to have to be doctors, and I think that's the part that most people don't realize. So, I think with that, I want to thank you for today's discussion, and we're going to continue this on next week with our discussion of how AI may impact healthcare in real ways. So, Chuck, thank you for this discussion, and we'll be online next week.